Thank you for joining today's webinar. Dr. James Bussel will now begin the program.
Thank you to the Foundation for Women and Girls Bleeding Disorders as we do our case-based conversation, safety and efficacy of classical pathway complement inhibition with Sutimlimab in chronic ITP. This was published in August of this year in Blood Advances, and in 2 minutes we will hear from the first author as she describes the findings. My name is Jim Bussel, and I'm a professor emeritus at Weill Cornell Medicine. The Foundation for Women and Girls with Blood Disorders mission is to ensure that all women and girls with blood disorders are correctly diagnosed and optimally managed. To this end, we aim to provide education to healthcare providers on the medical consequences and unique issues for women and girls with bleeding and blood disorders. Since its inception, the foundation is focused on realizing its vision through these objectives, as you can see here on the slide, and they range from understanding to education and training, collaboration, developing best practice, translating and disseminating, and educating and supporting the next generation. Changing to housekeeping to ensure the best sound quality, all attendees will be muted. However, you will have the opportunity to participate in a Q&A session at the end of the program. You can submit your questions during or after the presentation portion in the chat box, and then that's on the right side of your screen, and we will address them at the end of the presentation. CME will be provided by two physicians and nurses, and a follow-up email will be sent to attendees explaining how to obtain their 1 hour of CME credit. We would like to thank SOBI for their support of this program. These are the learning objectives for today's event. I think you're one slide behind. So, well, one more slide. Trudy, one more. I don't have the learning objectives here. I know I've seen them on a slide, but somehow they're not coming up. So basically, they're to learn about complement inhibition in ITP, specifically in regard to C1q inhibition, and toxicity, efficacy, and what therapies might be and which patients would be selected for them in the future. Our disclosures were listed on one of the slides that went by. We both have worked with a number of pharmaceutical companies, as you can see here. And Barbara Kunkel and Jim Munn are part of the FWGBD group to help with this. So you're going to hear about accreditation later, and before we start, we'd like to do a quick poll to see how many people are joining us today with others. Please take a moment to answer the poll question on your screen and select you're watching by yourself, you're watching with one other person, 2 other people, or 3 or more people. And if you would please answer that now, we would appreciate it. The option was for me to either sing the Marseillaise while you're doing this or to just wait. So I think I'm opting for just waiting. And hopefully you will have answered this, and I will get to see the results of the poll. And 95% of you said that you're watching on your own, so that's interesting. And I will now turn the program over to Dr. Catherine Broome. She went to med school at Louisiana State, did a family residency in Greenville, South Carolina, did her fellowship in hematology at George Washington, and then came to Georgetown University, where she's worked closely with Craig Kessler, who's now the head of the division. She's an associate professor of medicine at Georgetown and the medical director of Cellular Apheresis at Medstar, Georgetown, and is an absolute leader in the field of C1s complement inhibition in hematologic diseases. And we're very grateful for the opportunity to have her share her work with us today. Catherine?
Oh, thank you, Dr. Bussel, for that lovely introduction. We're going to move into the presentation portion. So I wanted to share with you initially what even made us think that complement inhibition would be a good target in patients with ITP, and then the results of our proof of concept phase 1 trial. So this is a story that may be familiar to many of you. A 42-year-old lady diagnosed with ITP in 2015. Usual presentation with bruises, some petechiae, and vaginal bleeding as well. From January to October of 2016, she had had IVIG twice. She had been on prednisone for more than 120 days. She had had rituximab 2 separate times. She underwent a splenectomy during that time. She was on vincristine for 4 weeks. And then 4 more times she had intravenous immunoglobulin. Unfortunately, she continued to have significant thrombocytopenia complicated by vaginal bleeding, which caused anemia. She also had an episode of GI bleeding, and she underwent a hysterectomy to control that bleeding. She presented to us at Georgetown in the summer of 2017. And from 2017 in June to March of 2018, so not even quite a year, she was hospitalized for a platelet count of less than 10,000 8 times for a total of 25 days. She was in our clinic either having a visit and or laboratory draws 65 times. And in total, she had 8 additional courses of IVIG to deal with the acute thrombocytopenia. She had 60 doses of Nplate and 6 doses of Velcade. And, you know, she had a lot of concerns, right? She was worried she was going to lose her job because she missed so many days of work. She was incredibly anxious, never knowing when her platelet count was going to be low. Felt like she couldn't make any plans for her life, felt chronically fatigued, was gaining an inordinate amount of weight, I think due to lack of exercise and others. And she was very anxious and afraid that she was going to bleed to death. And so she needed a good therapeutic option. It's not an unusual story for patients that have difficult to treat ITP. So you're all very familiar with the pathogenesis of ITP. We know that this is an autoantibody related disorder. Those autoantibodies are almost always of the IgG subtype. Once the antigen antibody complex is recognized, those platelets are opsonized. In most patients, most of that opsonization is going to take place in the spleen. But we also have a lot of other players that come into the picture, right? We have signaling between the B cells and the T cells. We have the production of those antibodies from the B cells. We may have inhibition of generation of platelets by activities between antibodies and megakaryocytes as well. And from a therapeutic standpoint, you know, you could see this patient kind of ran through the gamut, right? She had corticosteroids, she had IVIG, she had splenectomy, all of which are designed to try to minimize the platelet autoantibody production. She was on TPO receptor agonist, she was on Nplate, which is designed to help, you know, basically change that ratio between production and clearance. And then she also had other immunosuppressive drugs. She happened to have Velcade, but there are others that can be utilized, again, to try to interact with that T cell portion of what is continuing to generate the production of those autoantibodies. Now on here, we don't really see anything necessarily about what I'm going to talk about. So I just wanted to remind everyone that antigen antibody complexes, most commonly IgM antibodies, but certainly some subclasses of IgG, are going to have the potential to activate the classical complement pathway. And so the question that I raised in my own mind was, in patients like this who are having very hard to manage ITP, could there be another mechanism by which these platelets are being targeted for clearance from the circulation? Her spleen was gone and her platelet count was still many, many times less than 10,000. And so where was this stimulus for continuing to remove the platelets from the circulation coming from? And I wondered if it could be complement mediated. So while, you know, we all manage patients with ITP frequently, I just wanted to give a reminder that this can be a very deadly disease. And so patients do die from complications of profound thrombocytopenia. If you ever have the misfortune of it happening to a patient that you're caring for, it feels very devastating. It feels devastating that someone with a benign hematologic disorder perishes as a result of that. So just a reminder that it can be a serious disorder. We now know that complement is a driver of a number of diseases, and many of these are autoimmune disorders. There are now FDA-approved anti-complement therapies for neurologic disorders such as myasthenia gravis and neuromyelitis optica. There are approved complement therapies for atypical hemolytic uremic syndrome and C3 glomerulonephritis. Of course, we all know that there's complement therapy for paroxysmal nocturnal hemoglobinuria. There's also anti-complement therapy for cold agglutinin disease, which is an IgM-mediated autoimmune disease. We're learning that complement is also a driver in many other diseases like psoriasis, rheumatoid arthritis, SIRS, sepsis, lupus, cancer, surgery-related such as reperfusion injuries, asthma, adult respiratory distress, Crohn's disease, uveitis, myocardial infarction. So while it's been difficult to study complement, and it is tricky, and I think a lot of us tend to think of it as sort of a black box part of our immune system, it's kind of coming out of the shadows. We're being able to interact with it in very specific ways. We're being able to evaluate our the result of our interactions, and we're now finding that it is a driver or a mediator of many different disorders. So what about ITP? About 30% of people with ITP remain unresponsive to some of the current treatment modalities. And in my mind, that said to me, something's a little different, right? Is there an alternative component to the pathophysiology. We've known for a long time that about 50% of patients who have ITP have autoantibodies that can either activate complement in vitro assays or have complement detectable on the platelet, on their platelet surface. Now, a lot of people have said, well, that's just an epiphenomenon, that complement activation or that complement on the surface of those platelets isn't really part of their disease process. There's been some newer data that showed that complement deposition on platelet surfaces correlated with a degree of thrombocytopenia. So the more complement that was on the surface of the platelets, the more severe the thrombocytopenia. A third of patients with ITP have substantial reductions in their serum C3, C4, and CH50 levels when you compare them with healthy individuals. And while this is sort of an indirect measure, it gives us some indication that complement may be being consumed and used up in these patients. In an in vitro study, when inhibiting the classical complement pathway by C1s inhibition by a compound called TNT003, which was a precursor to Sutimlimab, they were able to show that complement deposition on platelets was reduced. And then in a couple of case reports, clinical benefit had been noted in patients with severely refractory ITP who were treated with a commercially available C1 esterase inhibitor. So again, immunoglobulin antigen complexes can activate the classical complement pathway. We definitely think about it more with IgM, but remember that IgG can do so as well. And so the IgG antigen complex is going to interact initially with C1q. That's going to set in motion the formation of the C1 complex, which contains C1q, C1r, and C1s. Once this complex forms, then you get activation of the classical pathway, and ultimately you're going to get generation of C3b, and C3b we know gets deposited on the surface of red blood cells in patients that have cold agglutinin disease, and it acts as a very powerful opsonin. What recognizes that C3b on the surface of these red blood cells, however, is the macrophage system that's located within the liver, not the spleen. And so again, could this be happening in patients that have ITP? What's so different about red cells versus platelets? We know that we don't have a DAT for platelets, and so we're not able to necessarily routinely detect this, but we questioned whether this could be playing a role, especially in patients who have very difficult to treat or refractory ITP. So here's the paper that Dr. Bussel alluded to. It was published in Blood Advances on August 16th of 2022, and it outlined and reported our findings in these patients. So what did we propose? We proposed that in a subset of patients, and we had no way of knowing how large of a subset, but in a subset of patients who have chronic, refractory, difficult to manage ITP, that perhaps the antiplatelet autoantibody antigen complex was in fact interacting with C1q and resulting in the generation of that C1 complex, which was then going on to generate C3b, which was getting deposited on the surface of platelets, and those platelets were then being cleared primarily in the liver by the monocyte macrophage system. So this was what we thought, might be happening, and we decided to utilize a drug that had been shown to be safe and effective in patients that have cold agglutinin disease, and that drug is Sutimlimab. It's a humanized monoclonal antibody that inhibits C1s. And so if you don't have C1s, you can't form an active C1 complex, and you don't get any activation of the classical pathway. It leaves the lectin and the alternative pathways completely intact. Inhibition of C1s pretty much exclusively prevents activation of C3 via the classical pathway. And so we hypothesized that a potential primary mechanism of thrombocytopenia in a subset of patients with ITP was classical complement pathway dependent, and that if we inhibited the classical pathway, their thrombocytopenia should improve. So the study was an open label study. We initially planned to enroll 16 adult patients who had chronic refractory ITP. They had to have failed 3 or more prior ITP therapies, and at the time of enrollment, their platelet count had to be less than 30,000 during screening so that they could be included in the study. They received either 6.5 gram dose or 7.5 gram dose, which was weight-based. They received a dose at day 0 and day 7, and then every 2 weeks after that, up to 11 doses. The study had a preset safety follow-up washout. So everyone came off of drug at that preset determination of time. We monitored them during that time frame. If their platelet count again fell to below 50,000 and they had responded in Part A, they were eligible to go into Part B, which was that it was up to 52 weeks of receiving additional doses of Sutimlimab. In Part B, they also got the loading 7 days apart and then an every 2-week administration. So we screened 16 patients. 12 patients were enrolled into Part A. Initially, there was a little bit of a difference in the dosing, but the vast majority, 10 patients, received either the 6.5 or the 7.5 gram dosing based on weight. 4 patients discontinued in Part A, and all of those were unrelated to Sutimlimab. They either needed rescue therapy or they were unresponsive as per the investigator's decision, and 1 did not have a clear reason for discontinuing. Then there was the safety follow-up washout. 8 patients completed Part A, and 7 of those 8 enrolled into Part B, and then 4 of those 7 completed Part B. And the reasons why patients discontinued in Part B were all unrelated, again, to Sutimlimab. 2 of them for need for rescue therapy, and then 1 patient also needed rescue therapy and decided to withdraw. So it was all about rescue therapy. And so here's our demographics. Our median age was 41. We ranged from 27 to 66. We had 75% female. About a third of the patients were white. 25% were Black or African, and we had 1 Asian participant. Disease duration, the median was 4.7 years. We had anywhere from 2 years to 36 years. The platelet count, the median at the time of enrollment was 19. And then number of prior treatments, the median was 5.5, but some patients, like the one that I presented to you, had up to 10 treatments. So almost everyone had received rituximab, over 80%. 66% had steroids. About 66% had some form of thrombopoietin receptor agonist, either romiplastim or eltrombopag. A little over half had IVIG. A smaller percentage had fostamatinib, and 1 patient had received rilzabrutinib. And then about a third of our patients had also had a prior splenectomy, like the patient that I showed you. So from the standpoint of treatment emergent adverse events, because there was no control arm, all events got reported. None of these were particularly significant. The ones that were possibly related included a couple of infusion reactions, and then one patient had bronchitis, and then one patient developed, well, didn't develop. One patient was diagnosed with a arteriovenous fistula in the face of a migraine, which was, we felt, unrelated to the study drug. And one patient had a flare of her previously known diverticular disease. We had no deaths, and we had no thromboembolic events. So we're giving an antibody. One patient did test positive for anti-drug antibodies prior to receiving Sutimlimab. No other issues were noted. The plasma concentrations increased rapidly after the dose, as expected. And then we measured classical complement pathway activity with a Weislab assay, and Sutimlimab rapidly inhibits this pathway. And then once we stopped it, of course, the pathway activity increased during the washout and then decreased again after restarting. Interestingly, changes in total C4 levels were consistent. So if you inhibit the ability to activate the classical pathway, C4 levels are going to go up, and they did that in all of these patients. And C1q levels actually remain completely unchanged. And that's important because patients that have low C1q levels have an increased risk of developing other autoimmune disorders like lupus. So if we look at the mean platelet counts from the baseline to the end of study, we can see that the platelet counts actually rapidly increased on these patients and were above 100,000 prior to day 7. They sort of maintained at a above 50,000 level. When the patients were washed out, platelet counts again fell, and then as the patients were retreated in Part B, the platelet counts again came up. So we felt like this washout was a really nice way of kind of reassuring ourselves that we weren't just by happenstance seeing an improvement in patients' platelet counts. In Part B, the vast majority of patients were on Sutimlimab alone. In Part A, at least half of the patients were able to come off of any other ITP therapy. And this is the mean C4 levels. One of the things we wanted to try to understand was, could we predict who was going to respond based on C4 levels? And unfortunately, we were not able to predict that. But what we did see was that all of the C4 levels went up. When you withdraw the drug, they go back down again, and then they go back up as you retreat them. If we look at complement activity, so the CH50 is in blue, and platelet counts are in green, and you can see that this drug rapidly inhibits the classical complement pathway, and platelet counts also rapidly rise in response to that. So we felt like it showed us that what we were doing with regards to inhibiting the classical pathway and the resolution of the thrombocytopenia were definitely temporally related. As we see the CH50 going back up during the washout, then the platelet count comes back down. C1q levels remain stable, as I discussed. And if we look at the median platelet counts, we can see at baseline 19, by day 1 up to 36, by day 7, 48, by day 14 up to 74. And then at the end of treatment, we had average of 54. During the washout, the platelet counts definitely went back down. And then during the Part B, the platelet counts went back up. whoops, sorry about that. So the main limitations of the study really are the single arm design and the small sample size. Both of these do reflect sort of the rarity of this very difficult to treat population of ITP patients. The lack of control group, we thought, at least in part, was addressed by the washout period and the retreatment. We felt that the loss of platelet count response during the washout and then the rapid restoration upon retreatment was fairly strong evidence of a direct clinical benefit of the Sutimlimab in patients with ITP. So it was associated with a rapid, within 24 hours, sustained and repeatable increase in the mean platelet count in 42% of this small population of patients with chronic or refractory ITP. I think this shows that there certainly may be a subgroup of patients where complement is playing a crucial role in platelet clearance. And it shows that C1s inhibition can be an effective therapeutic approach for patients that have failed other therapies. It supports the hypothesis that activation of the classical complement pathway contributes to that clinical heterogeneity of ITP. It further supports development of complement inhibition for patients with ITP that's not responsive to currently available therapies. My personal belief is that we have lumped together ITP patients for a little bit too long, and that hopefully we're going to try to understand that there are different subgroups of ITP patients and how to identify them from the very beginning of their disease course, so that we don't have cases like the one that I showed you where we're running through a variety of different therapies, not really understanding which ones may work better for certain subgroups of patients with ITP. So one of my hopes is that as we move forward with ITP, we're going to be better able to understand who might respond better to different therapeutic interventions. Thank you guys so much for your attention, and I will open it up to questions.
Thank you very much, Catherine. That was great. And it's also fascinating to me about how complicated ITP is. And whenever we look at it carefully, as you have done, you're opening another part of the envelope that we hadn't carefully addressed before. So we can take questions in the chat box, and what I'm going to do for the moment is to take the liberty of asking the first one, and then I will go to the ones in chat. In reading the paper, one of the things that I was fascinated about was, if I had this right, that all of your durable responders had failed thrombopoietic agent, had failed rituximab, and one of them had failed a splenectomy. So it almost seemed like you were doing a little bit better in the ones who had the worst disease, at least worst from the point of view of not responding to other therapies.
I think that's true. And, when we thought about how to design the inclusion criteria, not knowing how large this potential subgroup that might have complement as the main feature of their platelet clearance, we thought if we picked the hardest of the hard to treat, that might enrich our population for this alternative mechanism of platelet clearance. And the study, albeit small numbers, did seem to kind of corroborate that thought process, that no matter how much you tried to decrease IgG, remove the spleen, or even pound the megakaryocytes as hard as you could, if you've got generation of that C3b, you're going to have hepatic-based platelet clearance that you just can't get ahead of.
Thanks. That also speaks to the issue of just eliminating the IgG may not be enough if you can put C3b on the surface. So we have a question from Carol Matthew asking, could you please comment on the safety of this type of therapy in ITP in the presence of another autoimmune disease? So I guess maybe you could think about this. What if somebody with lupus had refractory ITP?
Yeah, so clearly this study didn't address that particular question, but as we look at the field of complement inhibition sort of in total, I think we are learning that it's a lot safer than we maybe originally anticipated, at least the currently available therapies. These patients were all vaccinated against encapsulated organisms, so they all had Haemophilus, pneumococcal, and meningococcal vaccines, and we saw, no infection signals in this particular study. C1 inhibition or classical pathway inhibition has also been utilized for very long periods of time in patients that have cold agglutinin disease. It's been utilized and studied in other autoimmune diseases as well. And so far, no safety signal from the standpoint of infection or other untoward safety signals have come up, and these patients were all monitored very strictly with an incredibly detailed panel of other autoantibodies just because of that concern about C1q. But since this drug does not affect C1q levels or C1q function, we saw no signal as far as the development of other autoantibodies.
So we could interpret that as not finding positive ANAs developing, for example.
That is correct.
There's a question about if you think this will be used in the pediatric population.
I don't honestly know the answer to that, because I think that in peds, most of these patients don't go on to develop a more chronic form of the disease. I think what will be interesting as we move the science forward is to try to understand whether it's a specific subtype of IgG autoantibody that's more likely to interact with complement pathway, and if so, is this something that's really present at the very beginning of disease? Is it something that evolves as patients have had the disease for a longer period of time? And I just honestly don't know the answers to that right now.
Okay. I apologize, that was from Nina Wang. There's a question from Lakshmi Srivas. Thank you for this very interesting study where your patients tested for C3, C4, and CH50, and I wasn't sure if she meant prior to starting therapy or on study, because you did show us some of the on-study data.
Yeah, so of course they all had baseline evaluations done, prior to initiation and then during the trial. And we were looking to see if even in this small number, we could see any kind of a delineation, right? If you had a C3 level below a certain amount, you were more likely to respond, or you had a C4 level below a certain amount, you were more likely to respond. And we honestly didn't see that kind of a signal. I encouraged the sponsors of the study not to really look at the numbers we had, because although many patients that came into the trial had a below normal C4, some of them had a normal C4 level, but then everyone's C4 level went up, and whether it was below normal or within the normal range prior to starting, it did not predict your response. And so I think that that may just not be a sensitive enough assay for us to utilize. I'm hoping that somebody who's really smart and who has a great laboratory will figure out a way to do a DAT-like test on platelets. You know, I'm hoping that we can eventually get to that point, but right now we don't have anything like that.
Just for your interest, many years ago we did a study that we didn't follow through on, but we did find a lot of people with low C4 who had chronic ITP, and we never really established whether was that a consumptive process, was that a genetic predisposition, et cetera. To the extent I would imagine that it goes up in pretty much everybody from what you said, that would sound like it might be more consumptive, but I guess it'd be nice to know that in more detail.
Right.
We have a question from Prasad Matthews. The slide for the platelet response went too fast. Could you show that again, please? And do you know what was the duration of response to one dose, and can these doses be repeated? That slide, by the way, is in the paper for anybody who pulls the paper, and I was assured that you've all received links to the article, so it'll be easy to find.
I somehow can't get the slides to go backwards, but maybe the host can work on that. So we, when we did the washout, the drug half-life of activity is right around 17 to 19 days. And so dosing every 2 weeks is designed obviously to have complete inhibition of classical pathway activity. In the washout, what we saw for most patients was that the platelet count started to fall right around day 21 to 25. So we were, you know, we did maintain platelet counts for a little bit longer than the technical half-life of the drug, but everybody's platelet count fell pretty rapidly during the washout period. And yes, all of these patients got repeated dosing. So they got doses every 2 weeks up until the wash. Thank you so much. They got dosing every 2 weeks up until the washout. And then in Part B, they also got dosing every 2 weeks after the first dose weekly for the loading dose. So with all monoclonal antibodies, you do that loading dose, and then every 2 weeks, these patients received drugs. So remember that in Part A, this is going to include everyone, even the non-responders. And then in Part B, of course, you couldn't get into Part B unless you had previously responded in Part A. And you see the platelet counts represented there.
We should take a minute to thank Trudy Curtis, who's managing the webinar for Foundation for Women and Girls Blood Disorders, for being able to put the slide up and helping us with that. Next question that I have, also from Lakshmi Srivats, is, could you comment on whether this medication will be or will not be useful in patients with autoimmune disorders whose levels of C3, C4, and CH50 are affected?
So, you know, I think that that's to be determined. I don't know how beneficial classical pathway inhibition is going to be in any given autoimmune disorder. I think that the science and the information is definitely exploding, and there are multiple clinical trials looking at classical pathway inhibition at the level of C1s. There's classical pathway inhibition at the level of C3. There's alternative pathway inhibition with factor B and factor D inhibitors. So I think we're in an explosive phase of understanding and knowledge building about how interacting with complement might benefit any one of these autoimmune diseases where C3, C4, and CH50 are low.
Would you, if you had inhibitors available to you to do a study in any one of those, with any one of those complement inhibitors, would you automatically pick the inhibitor of C1 or not? Or would there be benefits to using other agents?
So I think that I like the very pinpointed action of only interfering with classical pathway activity and leaving the entire lectin and the entire alternative pathway intact from the standpoint of, I think, minimizing risks of adverse events for patients. Now, is it the right pathway for all autoimmune diseases? Maybe not. Maybe alternative pathway plays more of a role in some than others. And so, again, I think that it's going to be a little bit of, quote unquote, no pun intended, trial and error, right? We've got to do the clinical trials. We've got to see, what activity do we get? If we don't get what we expect, is it because our target is off? Do we need additional target? Do we need an alternative target?
And just before we leave this, I had always thought that the inhibitor of C5, eculizumab, would have been tried at least years ago in ITP, and the reason it wasn't was not because people thought it wasn't safe or wouldn't work, but just because it was so incredibly expensive.
Yeah, so I'm not sure how much benefit we would get, because I think, like in cold agglutinin disease, the majority of the damage is being done proximal to C5 at C3. And so whether or not there's a huge component or any component of membrane attack complex generation in ITP, I don't honestly know. Obviously, if we inhibit at the C1 level, we're not going to get C5 generation because you need C3 in order to generate C5. So we've stopped it, but I think it, like in CAD, where it can help some, but C1 is better. I think in ITP, it may be that inhibiting higher up in the pathway is a little bit, potentially a little bit more efficacious.
If you will excuse me for using my prerogative as moderator, first, I neglected to say that Dr. Broome is going to be presenting in the plenary session in ASH next month on a separate study not involving Sutimlimab, but this is the first time that ITP has been in the plenary session, to the best of my knowledge, since 2007, and we're all very much looking forward to hearing her there. And the second thing, just to point out, is that the Beutler Award lectures at ASH this year are on complement inhibition, and there'll be a basic science presentation from Dr., I believe, Atkinson, and then the clinical presentation by Peter Hillman, who did some of the early work in PNH. So I apologize for that interjection.
Well, I'd encourage everybody who can hear the Beutler lectures to listen. It's going to be very exciting, and I think, in our world, of benign hematology complements one of the new and very exciting things. And the more we understand it, the more we think about it, the more we query it in different disease processes, I think we're going to learn a lot. And both of those they're great speakers. So I think it'll be a great lecture.
The next question is from Mira Chitler, and I apologize to any and all people whose names I'm mispronouncing terribly. Would like your thoughts on the patient who had thrombocytosis with the combination of the TPO agent and Sutimlimab. Question about the mechanism, and could this be a potential therapeutic option, I guess, as a combination treatment in some patients?
Sure. So this happened to be my patient, so I am intimately familiar with the whole situation. And basically, what happened was that we started the clinical trial without a mechanism to continue it for patients that were going to respond, because I think that sponsor maybe wasn't convinced that we were going to have any responders. So we did have early responders, and we were rescuing this patient with a dose of romiplastim, and then it became apparent within 48 hours that we could continue with the study medication. And so again, I think we, created a perfect storm where we encouraged her megakaryocytes to start making a ton more platelets. And then we also very rapidly, and, not necessarily reported in the study, but in the small print in the paper, and I didn't highlight it in my slides, but many of these patients will have a pretty rapid, within 4 to 8 hours of increase in their platelet count. And so she got the TPO, and then she got study drug, and within several hours, her platelet count started rising and went over 1 million for sure. We held the study drug as protocol demanded, and of course the thrombocytosis resolved. I do think, that in patients who maybe have issues with platelet production as a component of their ITP, that combination therapies are always something that we can consider. It will take some fine tuning, obviously, and a better understanding. Again, the patient got a pretty large dose of the TPO mimetic as a rescue dose. Probably if I was doing a combination, I'd go with much smaller doses of the TPO mimetic if I was going to use it in combination in somebody who I knew was responding to this drug.
I think if David Cooter were asked, he would point out that the TPO agents are really the only treatments of ITP, or almost the only, who have any degree of overshoot of the platelet count. So we have another question, and I apologize because I don't have the full last name in a way that I can read it. The question is from Bharadwaj Kolapak, and then I don't know what the rest of the name is. Would you expect better response to this agent in those who fail splenectomy, as it seems like this helps in those cases where hepatic sequestration is the primary pathway involved?
So whether you had a splenectomy or not did not seem to in any significant way predict whether you were or were not going to respond to this drug. So we had responders who had splenectomy. We had responders who had not had splenectomy. So I don't know if that's the greatest predictor. There are some data, and this is something that I think would be interesting to explore. So I'm sure all of you are familiar with the data about desylation of platelets and how that impacts hepatic clearance. There's data that says that in the neurosystem, in the brain, that desylation allows for increased complement activity. And so I wonder, are these two things linked? And when we started the clinical trial, I honestly didn't know enough to ask that question, and we didn't query it in any of our correlative studies. But there I think is an opportunity to try to understand whether those two phenomenon in some way are linked.
That's really interesting. And I would like to follow up on that just to ask, in the cartoon that you created and you showed it to us back in the beginning of your talk, the implication is that the complement doesn't get on the platelet unless there's IgG or IgM to fix it and put it there. If that's correct, would you think that if you knocked out the antibodies a fair amount, you know, daratumumab, rituximab, an FcRn inhibitor, that would be synergistic as well?
Maybe, but remember that we've never seen a good linear correlation between antibody titers and thrombocytopenia. And we know that, you know, some patients, we can't detect antibodies at all, and yet we still believe that they definitely have ITP. So I think that the ability of a specific antibody subtype to activate complement may not be linearly related to titers, but more so amplitude or activity levels.
But do you, I guess what I'm curious is, I apologize if whatever,
Okay.
if you have platelet antibodies, IgG platelet antibodies, let's say, and you're clearing a platelet, then theoretically, if there's also, let's say, C3b on the platelet surface, presumably the combination of IgG and C3b should be more efficient than either one alone, and that would be extravascular,
Correct,
cytolysis or an extravascular clearance. But do you think there are patients who just have circulating C3b and they're cleared in the liver?
I don't know, but you know, you would have to presume that that's happening in somebody who's had a splenectomy, right? So maybe, but to your point, I think that, you know, there could certainly be IgG and C3b on the surface, and if we were able, with daratumumab or neonatal Fc receptor agonist, to reduce the amount of IgG, and then in a synergistic way reduce the amount of C3 generated, we might get much more response rate, a higher response rate in a larger number of patients. I think that's a really great thought.
So before we get to the last question, Dr. Chitler is putting in a note saying thank you for a great presentation. And I'm sure we would all echo that.
Thank you.
Dr. Vanessa Salinas asked, would you expect a more sustained response if Sutimlimab is combined with an immunosuppression?
Perhaps. I mean, I think that's just the same question that Dr. Bussel was asking, and you know, how we would combine these things would be very interesting. There's some in vitro data suggesting that inhibiting the classical pathway in autoimmune disorders in general may actually inhibit signaling between the T cell and the B cell that may allow over the long term for some type of resolution of the autoimmune process. And so I think that, you know, longer term evaluation of patients and what actually we're doing overall by inhibiting signaling pathways in addition to inhibiting production may enlighten us as to the role of complement in the propagation and the continuation of these autoimmune phenomenon. So I think those are all questions that beg to be answered with additional study.
And I did Dr. Chitler a disservice because she had a question and I didn't fully read it. So in addition to thanking you for the great presentation and answers, would there be a concern with very long-term inhibition of complement in this manner? Or another way to say this is, how long could you use this in a given patient? And do you think it's necessary to stop after some period of time?
So this study, the way that this went was that patients would receive it up to 52 weeks after the last patient in. So patients in the ITP study were on the drug for, the longest patient was on for almost 4 years. We didn't see any concerns and it never stopped working. In cold agglutinin disease, patients have been on this drug now for over 5 years. And again, still no concerns, safety signals, et cetera. So I don't think that there are any known concerns. We know that eculizumab is something that can be continued for long term as well. So I don't think there's a reason to have a prescribed stopping time if we're using anti-complement therapies.
So I think we're going to end there. There aren't any other questions in the chat. I think, Dr. Broome, that we have to again thank you for your presentation and question answers and the way you're pushing the field forward, and we will look forward to hearing more from you in the future. The Foundation for Women and Girls Bleeding Blood Disorders is pleased to provide this program at no cost. And you will receive, the attendees will receive the evaluation following the program. Please complete it so you can then get your CME credits. We would like to thank SOBI again for supporting the program. And we would be very remiss if we did not also thank, in addition to Trudy Curtis, Catherine Cantu Anguiano, who helped organize this for the FWGPD. So thank you all for your attendance, and we hope you'll participate in other programs in the future. Thank you.
Thank you all.